Good afternoon, dear colleagues, and welcome to session dedicated to left main and complex bifurcation stenting. Bifurcation stenting in generally is still one of the most complex interventions. The number of people here in the audience really justifies the need for more education, and our goal today will be to discuss left main plus complex bifurcation PCI of the LAD diagonal. My name is Goran Stankovic. These are my conflicts of interest. And today we have a great team to discuss complex left main trifurcation LAD diagonal PCI. Together with me is Tom, and then we have fantastic discussants, Dr. Kinoshita, Jens Lassen, Maciej Lesiak, Francesco Burzotta. And we have a great team in Massy. Traditionally, this session is a TNT session organized by and sponsored by Terumo, and we have a live case demonstration from one of the best centers in the world from Massy, with Bernard, Thierry, and Yoshio Numa as a guest operator. Our objectives for today are to discuss and to try to understand what are the best treatment options for patients presenting with left main and complex bifurcation lesions, to learn how to optimize both the strategy and the technique using optical frequency domain imaging technique, to understand the mechanical properties of new generation Ultimaster Nagomi drug-eluting stent, and share the latest results. Please use your mobile application or standing microphones here in the room to ask your questions. We have plenty of time for discussion. Please use the opportunity to share your questions, concerns, comments, or suggestions. We will be more than happy to address. And PCR is all about case discussion and the best way to improve clinical outcome of our patients. So we will start with a case presentation. I would like to invite Tom to present today's case.
Brilliant. Thank you, Goran, and thanks to Terumo for supporting this session, and welcome everyone. So this is a case of distal left main trifurcation with additional bystander disease in the mid-LAD, as we said, broadcast from Massy. So our patient is a 75-year-old gentleman, active, former retired engineer, with CCS class 3 symptoms over the last 6 months. As is practice, certainly for us in the UK, he has gone through a CT scanner prior to coming to the cath lab. He's 185 centimeters, 102 kilos. He has cardiovascular risk of hypertension and former smoking, and paroxysmal atrial fibrillation requiring anticoagulation with a CHA2DS2-VASc score of 3. He's on, as I say, apixaban, flecainide, and bisoprolol. These are his lab findings. So he's got a normal hemoglobin, importantly. He has a significantly raised LDL, which I think is probably as impactful as the intervention we're going to witness. We need to ensure that his risk factors are appropriately controlled. He has normal renal function and is obviously troponin negative. This was his resting ECG. He's had an echocardiogram with normal LV function, no significant valvular disease. And I think really most importantly, it's an opportunity for us to review his CT scan before coming to the cath lab. And certainly this is something that increasingly in our practice we are trying to make time for, because there's an incredible amount of information and opportunity to be obtained in assessing this CT images prior to embarking on the procedure. And these are his coronary pictures, which we can look at together, showing moderate distal left main stem disease, a relatively large circumflex, which may be defined as codominant, and then this mid-segment LAD disease extending to diagonal. But I think at this point we turn to Francesco to review the images that we've got so far.
So we have actually clearly a patient with the coronary heart disease deserving for treatment. And the flow of the workout included the CT scan that is becoming more and more part of our practice in those patients that are stable. And so I would like to start reviewing the CT scan there were many images, but I think that this image is probably the most important one, since it allows us to understand that we have definitely area of disease here in the LAD at the level of diagonal takeoff. And we have definitely also some disease at the level of the left main. In between, we see that with a way of assessing by imaging atherosclerosis, that is CT scan, that is quite sensitive, we see that there is an area where we have doubt about the presence of important disease. So the first question I pose on the basis of these images that should be in the mind of the operator planning to perform a PCI, which can be the best strategy when you have in mind this kind of workout done on the basis of CT scan. So, which is the reaction when you go back to plan your procedure according to these images taken at CT scan.
Yeah, thank you, Francesco. I'll go to Maciej because there is also clinical risk. This is a 75-year-old patient. There is bleeding risk that is increased, plus use of non-invasive imaging. If you put everything in context, what are your general concerns?
Yeah, definitely we are dealing with patients with high bleeding risk because of this age, 75 years old, and because he needs to stay on the oral anticoagulation due to AFib. And I just want to remind you that the risk of death is increased by bleeding the same as it is by myocardial infarction, and even if bleeding occurs shortly after procedure, especially in ACS patients, then the risk of death is even higher after bleeding than after acute MI, even if the bleeding is not, mortal, if this bleeding does not even need to do blood transfusion, mostly because people very often stop dual antiplatelet therapy then and put at high risk of ischemic complications. So this is not a trivial fact that this patient is high bleeding risk. Then we have an issue of combining medication. I think he should stay on triple antiplatelet therapy at least around the procedure, perhaps within one week of the procedure, depending on how complex it will be. If there's simple procedure, then we can shorten. And of course, as follow-up, we have enough data from master DIPT study with Terumo stent, with Altimaster stent, that we can very safely shorten the dual antiplatelet therapy to 1 month only, without reducing thus reducing the risk of bleeding, without any signal of increasing risk of ischemia. So I think that's an ideal patient for this kind of strategy.
So it's really a large clinical endpoint-oriented study that tested this hypothesis. I believe this is very convincing. Although I think we should use all our best knowledge to make this procedure as simple as possible. Jens, what would you like to share? How much you use non-invasive CT before the procedure for procedural planning? And in this specific case, we see some diffuse disease. What is your interpretation of these findings?
Well, thank you for that question. It is a complex patient, and I totally agree in what we have said before. So my first concern will be, there is a high bleeding risk. I would like to reduce the use of oral anticoagulants in that setting and DAPT, which means that I would like to do as simple as possible a procedure, reduce the metal, and do what I need to do to solve the angina problem without putting in too much metal. And that means, of course, evaluate the CT scan. There is information about calcium, but it also points to the fact that we might need even more imaging to make sure where the landing zone is, where we have the maybe problematic calcium nodules, all that kind of things during the procedure. And maybe also take a look at the physiology to see where do we have the drop in pressure.
Let's see the angiograms.
just bring the presentation back up if we can.
Yeah, I think you can do it.
So we have got some interaction as well. So there's one prompt from the audience about whether we should be loading with aspirin and clopidogrel before the procedure, and there's another around the techniques, which we may come back and address in a moment. So we've seen very usefully from the CT, there is a degree of calcification. There's that concentric element around the level of the mid-LAD and bifurcation, as Francesco has alluded. And then here we have the angiographic images with, in this spider projection, evidence of distal left main stem disease, this large circumflex artery, and then extending into the LAD. I'll just work backwards first, as we missed that cranial projection, which we just play again. And we see there then this significant segment of disease extending from a major diagonal branch into the mid-vessel.
Yeah. Okay, Francesco, can you lead us through the anatomy that we see on the angiography and describe the plaque distribution? Because here we see trifurcation, but most of the plaque seems to be in front of the ostium of the LAD.
Yes, so we'll do in a minute, and we'll do on the basis of angiography, but I think that it is important to remember the Jens suggestion about the possibility to use intravascular imaging to plan this kind of procedures in the case you are going to treat the left main. There are increasing data that support the use of intravascular imaging. In doing this, I think that if we come to the CT scan, there is an important message. If we have both IVUS and OCT that can be discussed as possible alternatives to perform imaging, if we want to apply OCT to the left main, we know that we are not able to image correctly the area of the ostium that is instead very well captured by IVUS. So in this case, CT scan says that there is no huge plaque over there. So I think that it is also suitable for the OCT investigations, or OFDI for sure. I mean, we have different ways. So regarding the plaque here, I see that there is a long plaque, irregular plaque, with some pinching in the diagonal. So I think that this can be classified on the basis of angiography as a Medina 1-1 lesion. Here, I see in this view that there is the tightness of the disease. It is apparent in the distality, so there is definitely a huge plaque over there. But when you go in the cranial view, what you see is the fact that the plaque seems to be distributed like that, jeopardizing the ostium of the LAD coming from the lateral wall, while on the opposite, toward the circumflex, I do not expect to have a lot of disease. This is very important because if confirmed, or if, let's say, checked by intravascular imaging, it can increase the potential to have few risk of complications into the circumflex, and it can really be an anatomy very suitable for provisional.
So if provisional, what about LAD diagonal, also provisional?
Yeah, I think the only risk is that there's a very narrow angle. Yeah, so of course this vessel definitely needs to be supported with protected with wire. This is an important vessel, but still we can approach with provisional strategy.
Yeah, so two bifurcations, major bifurcations, left main plus LAD diagonal. According to Francesco's nice explanation, a risk of compromising the side branch seems to be low, so we start with provisional. And I would like to ask Dr. Kinoshita to share his own strategy and then present also the new generation, latest generation Ultimaster Nagomi stent, which has several advantages compared to current generation Tansei.
Okay. Thank you, Goran. First of all, I want to talk about my strategy. As Dr. Larsen said, I think that for this patient, also the simple strategy is best. But the simple strategy, when considering about simple strategy, just putting the stent with a provisional stent, So, but this patient is a high bleeding risk patient. If I use a long stent, we have to continue the dubbed triple therapy.
First triple and then the APT.
And so, and if we want to put the we don't want to put the long stent. Now at that time, we have to much care to deal with each bifurcation.
Yeah. Can you present the features?
Just before that, as you come and
please
bring
come.
the slides up, let me just bring in some of the interaction from the audience, because I think before we dive into stenting this vessel, we do have to broach surgery versus PCI, and we have here some questions challenging. Should we use the CT in order to promote towards bypass surgery? Well, that has been looked at in the Syntax 3 study and shown in just over 200 patients, the utility of CT to actually guide decision-making towards bypass surgery. And then another question about whether we should be scoring this patient by Syntax. I'm sorry, I didn't have time to show you those slides. There was actually equipoise relative, in fact, slightly less in terms of likely event rate with PCI versus CABG with this patient. And as Dr. Kinoshita has already highlighted, really it's the HBR element that was the greatest component of risk that came from the scoring assessments.
Any comments about PCI versus CABG? Jens, Maciej?
Yeah, this is a patient with isolated left main plus another vessel. So we have just left main plus one vessel. So I think there is absolutely no indication to do CABG in this patient.
And especially based on the Syntax 2 calculation.
Yeah.
Dr. Kinoshita, please.
Okay. Thank you, Goran, and ladies and gentlemen. It's my honor to have this time with you. So today I would like to talk about the new Ultramaster features. Maybe the new Ultramaster is very suitable for such kind of this case. So this is my CY slide. And so first of all, I would like to talk about the difference between the old Ultramaster Tansei and the new Ultramaster Nagomi. Old one is it's a albuminal coated, sirolimus coated 2-ring 8-crown designed. But this time, Ultramaster Nagomi is upgraded to the 2-ring 10 crowns. So it means this change improved not only the expansion of the stent itself, but also the expansion capacity of the cells. So this time we tested these two stents using the two different type of the experimental vessels. This one. And so the procedure, the detail of the procedure is like here. Yes, and in this test, bench test, 5 items were evaluated to see the adaptability of the bifurcation region in this two stents. The one is a cell opening. Cell opening was calculated by using this figure. Sorry, and then in complete stent position. And proximal main branch stent deformity, we call it left main density, and then distal left main left main branch stent deformity, we call it bifurcation density. And the last one is the expansion capacity. It's evaluated the combination of the instant position and the strut angle using this table. So the strut angle was divided to the 130 degrees, and the incomplete stent position distance is 0.2. It's limited. Okay.
Yeah. Thank you so much. So to summarize, before connecting with Masi, we have high bleeding risk patient with left main trifurcation plus bifurcation LED diagonal. Based on the risk evaluation, decision was made to be treated percutaneously, And our team, I think, has agreement that provisional strategy for both vessels is the best option. Let's connect with the Massy. Dr. Kinoshita, please take a seat. Let's connect with Massy and see what strategy Bernard and Thierry decided, and I'm sure they also did OFDI evaluation.
Okay, good afternoon.
Good afternoon.
Good afternoon, everyone.
Good afternoon.
Welcome in Massy. We're very delighted to be in this session with you. I'm going to do the case with my colleague Bernard Chevalier and Dr. Onuma as OFDI expert. We are doing the case with an anesthesiologist, Dr. Dermosh, and Sophie and Natalie as nurses. So I think the presentation has been done, Bernard. It's time to start.
Yes, it's time to show the key objective and strategy and tools and technique of this intervention. Next one. So the key objective is to show you a double bifurcation treatment, one on distal left main, one on proximal LED, using pre and post OFDI assessment. And the strategy will be to perform provisional stenting on both bifurcations. So the strategy, as said, is to go from the transradial access, which is the 7th French. We are going to assess the lesion first by OFDI. It was already done, and Dr. Onuma will show us that very soon. We wire the three vessels, LED, diagonal, and circ, and trying to achieve a provisional stenting with predil of LED and pot after stenting. And then remove the diagonal wire and go to left main bifurcation with left main to LED stenting with pot and kiss. And of course, we'll finish by OFDI. The tools of today are 7 French glide fish slender introducer with EBU4, run-through wires, OFDI from Terumo, NC balloon for LED and also for post-deal. And we plan to use 2 Nagomi stents. So you can see here again the international team. I think it's time to see the OFDI with Yoshi Onuma.
Yes.
Thank you, Yoshi.
Can you see the images? Maybe could you put the OFDI images on the screen? Yes, yeah, thank you. So this is a pullback from the mid LED. You can see the distal part is a 2.7. I will come back on the measurement. There is a diffuse disease with some lipidic and mixed plaque. You can see the tight region here, and there is some lipidic component with some attenuation. And you can see that there is some calcified plaque, which is usually both sides of the vessel, just around the diagonal. You see this wire of the diagonal is coming now into the LED. There is a relatively preserved lumen with the 3 mm in diameter, and there was also the fibrotic plaque in this proximal region. Ostium of the LED is very much stenosed, together with this distal left main also very much stenosed. I will show the measurement there, and then there's a diffuse disease up to the proximal part of the left main, but proximal part looks like minimally diseased. So you could see that I will show some measurement. So you can see that here will come back from the distal. So distal reference is 2.62, and you can go to the around the diagonal branch, some calcium extending almost 270 in degree. However, this is a very short calcification, less than 5 mm, and then you can see that some 3 mm in diameter. So maybe the proximal landing zone of the distal stent could be around here with the 3 mm, and then you see the significant stenosis in the LED ostium with the minimum lumen area of 2.66. And you can also see that the left main has the distal left main has a significant stenosis, diameter 2.36, area is 4.4 square millimeter. So I think it's also functionally very much significant, this disease. And proximal difference for the left main is 4.03 in diameter. So In total, if you try to cover from the distal to the left main, the length will be 52.4 millimeter. And if you try to make a 2 stent, maybe you can use cover the first stent with the length of around 26. Second stent maybe also around 26 in length.
Okay. Thank you very much.
Thank you very much.
You can show us. You can show the images of today, starting from the two
angio images acquired today.
So what we have done so far, so this is the first injection without any wires.
Can we have angio on the screen?
Lesion.
Thank you.
Yeah. So you see the tight lesion of the left main, and there is a 3 run-through wires through the circ, diagonal, and LID. And you can see this tight lesion of the mid part of the diagonal. And I remind you there is a ring calcification on the CT scan, which was confirmed by the OFDI. So we decided to use a non-compliant balloon, 2.5, to predilate the mid part of this LID. And now we're going to show the result after predilatation.
So to summarize, Thierry, decision is to use a medium vessel platform to cover this LAD diagonal bifurcation segment. Proximal and distal landing zones are selected according to OFDI evaluation, and after lesion preparation with the NC balloon, this is what we have now. Any comments, Tom?
Well, yes, there have been some questions. One was, why do the CT, or other way around, why do the imaging if you've done the CT? We have information. And I think we have to see that as complementary. So the CT was diagnostic to get the patient to the cath lab. And now we have this incredible information from Yoshi. I must say, I thought the left main was moderate and may not be significant, but to have reached an MLA of 4.4 quite clearly demonstrates the significance of that.
And also now we can optimize the procedure with
and we've demonstrated, I mean, actually it very nicely mirrors the information we had from CT to OFDI. We see the non-concentric, but almost 360-degree arc of calcium, albeit, as Yoshi says, over a relatively short segment. But there absolutely is the need then to undertake careful predilatation. Yoshi's shown us as well then that the Ultimaster technology has evolved. So we've gone from the small vessel to large vessel to now small, medium, and large. And yet, historically, the small vessel was able to go up to 4.2. We now have this medium vessel technology that can go to 4.8 millimeter, and the large vessel will go to 6.2. So that issue around tapering vessel, we can overcome. Can you do it with one stent? You had 50 millimeters. We've said 52. The Tensine, the new stent Nagomi goes to 50 millimeters in length. So there's now a new 44 and 50 millimeter platform. But we probably do need to then stage that across 2 stents if the disease extends more than 50 millimeters. So the combination of CT, OFDI, and now this new technology gives us lots of options.
But I'm sure that using 2 stents, 2 different platforms, you are able to have much more symmetrical strut distribution, better optimization, instead of striving to have 50 millimeter and having a risk to land inside the lesion.
And lower the risk of carina shift for the diagonal,
Exactly.
Because if we put 3.5, then the risk is much higher.
So in terms of the diagonal, Maisha, there's a comment here, anonymous, but do you consider it mandatory to wire both the circumflex and the diagonal? It's a provisional approach. Do we just keep it simple, one wire?
I'm putting wire anytime I do this kind of procedures. I don't think there is, because the distribution is on the other side. So the risk is not high, but it's not a big issue.
But as soon as it's true bifurcation, I think it's much safer, more predictable, and gives you simplicity in recrossing if necessary. So I would always advise 2 wires. If it's bifurcation, 2 wires, work on the main vessel, optimize, but keep wire in the side branch until you finish with pot.
I totally agree. But another thing that also is appealing with this case is that we use 2 stents and pay attention to one bifurcation at a time instead of trying to make one size be modulated to fit all. Because then you actually take really care and simplify the procedure for each bifurcation, which is appealing because we want to lower the time for dual and triple antiplatelet therapy.
Mm-hmm. Another limitation of using very long stent in this situation will be J-link diagonal wire with very long stent.
Yes.
Yeah? So that's
50 millimeter.
another issue.
Thierry, you are using stent boost now. Can you please help our audience better understand decision making behind that?
Yes, as I said, we use a 2.5 28 millimeter Nagomi stent. It was implanted at 14, then we go to 16 atmospheres after first stent boost. We think it's very useful to detect very simply under expansion. And we have seen that we have, because it's calcified, we see also very well the calcification around the artery on the stent boost. And now we are going to perform the POT in the Paroxymal AD with 3/0/8 in order to comply with the eye data.
Thank you, Bernard. We published successfully Ultimaster registry data on bifurcations. You were the lead author. And this is one of the most important contemporary practice analysis showing that if you do proximal optimization, you improve clinical outcome directly. If you want to mention the results in more depth.
Yes, I think it's very important. It was a huge cohort in this Ultimaster registry, more than 4,000 bifurcation lesions. And I think it's the first time we show clinical benefit. We reduce from 6 to 4% the rate of TLF at 1 year just by doing a POT. And I think it's a very convincing data to generalize this approach. The POT is very important because you select a stent according to distal reference, and to correct this undersizing of the proximal part. The POT is a key element in the approach of bifurcation lesion.
Now you can help us better understand the position of the POT balloon. I see that you use short balloon, but can you lead us a little bit? How do you get the best position of the distal marker?
I think it's very important again. The right position is always beyond the divergence of the wire, as you can see on the stent boost. We use both stent boost and injection to be sure that we are at the right position. This position there is probably too proximal, as you can see. And we need to go a little bit beyond the divergence of the wire to be sure we are in the right position.
Yeah, wires are diverged just to help our colleagues. By implanting stent, you actually push laterally a wire that is jailed in the diagonal. So recrossing point of the wires is always more proximal than the real actual carina. And that's why you are explaining to Thierry to go few millimeters distally and be with the distal marker just in front of the carina. Any comments by the experts?
Yeah, so sometimes we use the IBUS to decide the correct pot point, because on the angiogram sometimes the bifurcation angle just distal carina side is a little bit different to see the angiogram and the IBUS. So using by check the IBUS or OFDI, so the mark put on the mark the correct bifurcation.
Yeah, I think you did excellent 3D study in Japan with OFDI that you documented. If you are guided by angio only, you are in only 50% of cases able to really cross appropriate distal cell. You need to use imaging if you want to document that you really cross the distal cell, and then push that metal to scaffold the ostium of the side branch. Maciej, any comments on that?
Also very important is position of a pot balloon, because if you position your pot balloon at with distal marker at the level of carina, then the chance that the distal strut will be the bigger one is very high, and then you increase the possibility, you increase the chance of getting through the distal strut. Otherwise, if you are too protective and you position too proximal the pot balloon, then not the distal strut will be the biggest one. Yeah, so then the chance of crossing distal one is small. smaller. So with right positioning of pod balloon, you increase your chance of crossing distal strata.
Okay, Bernard, your KISS trial really helped us understand that outside of the left main, no need for routine kissing balloon inflation is required. But can you comment on this result now?
It's a typical example of patients from the KISS trial. So the side branch is patent after doing the POT. And this is the type of patient we randomized between side branch and no side branch interventions. And clearly, we did not prove any additional benefit to do side branch intervention, either with kissing or POT side POT. You just prolong the intervention with more contrast, more X-ray exposure, and you need more frequently to stent if you do side branch intervention. And there is no drawback in terms of peri-procedural MI. So this is the reason why we are going to switch directly to the second stenting. We have first to remove the diagonal wire. So it's very important what Thierry is doing now is pulling on the guiding catheter to avoid any jump inside the left main. Concomitantly is pulling on the wire to maintain the position of the guiding catheter.
So Bernard, just as you're in the process of moving to the left main, there's been a useful question asking, it would be nice to have your opinion on how you site the stent proximally at the ostium of the left main. Do you go for roof or floor, or are you going into the body of the left main here in terms of your proximal position?
I think we plan to end up at the mid part of the left main. We discussed that with Yoshi before the live. And Yoshi, what is your point of view regarding the very proximal part of the left main?
Yeah, I think proximal part of left main is minimally diseased, and lumen is 4.0. So I think you can land this part of the left main, mid part of the left main.
Great. And Yoshi, there was another comment asking why we hadn't imaged the ostium of the circ, but I'd argue that the CT scan has probably given us enough information there in terms of presence or absence of circumflex disease. But certainly it would be an option to image both limbs of the bifurcation, wouldn't it?
Yes, of course, it's an option, but of course we have to think about the total amount of contrast. We have some input, I think, from OFDI. We can have some guess regarding the ostium of the left main, which is relatively large. You can see on the angio that the circ is a bit aneurysmal. So I think we are now in a positioning of left main lesion.
So we are going to position the proximal stent, which is a 3.5. I used the stent boost to focus on the distal part of the stent in order to have a minimal overlap. And so it seems to be good at the distal part. And now I'm going to inject some contrast to see where is the stent regarding the left main.
And Thierry, we've also been asked how long do you want to inflate the balloon? And I guess that's particularly relevant in the left main, including proximal vessel. I wonder if we could have the hemodynamics up at the point of stent deployment as well. How long will you plan to inflate this balloon?
Good, huh? So usually we use 30 seconds inflation.
Actually, the decision of the proximal left main, the ostium is very using by the OFDI OCT. It's one of the weak points of the OFDI OCT because it is difficult to flush out some kind of the blood cell, and it is difficult to see it clearly. So sometimes in some guide extension,
guideliner may
guidelines are difficult. The Medtronic telescope is very good.
Sorry, Thierry.
So we are inflating now a left main stent, 3.5, 24 millimeter long. You can see.
Can we go to live angio image now?
Tolerance in terms of hemodynamics. There is no drop in the pressure. On va déflater là parce qu'il commence à bouger.
So we tried to keep at least 20 second atmosphere in the left main. So
when we see hemodynamics,
as usual, Yeah, the hemodynamic is quite good. It was a little bit dropping at the end of the inflation, but it's quite usual. Okay, so now I'm in the caudal view.
Again, very important point to get control of the guiding catheter with left hand to avoid any longitudinal compression. This is one of the advantages of not going up to the ostium with a stent, that you limit the risk of conflict between guiding catheter and the stent.
Okay.
Now we are going to perform POT in the left main. We selected a 4.5 because we think that the 4.0 is probably a bit too small.
So Bernard, there's a question in the room whether you pre-dilated the left main, or were you happy that it was soft plaque by CT and OFDI that led you just to direct stent? I missed whether there was a pre-dilatation.
We did not pre-dilate the left main.
It was direct. Yeah. Because it was a soft plaque confirmed by the OFDI findings.
Yep.
Okay, the ECG is okay, so we are pretty confident everything is patent. So we're gonna do the POT with the 4.5 8 length balloon. So as was shown before, the POT is really key, particularly in the left main. So I like to magnify a little bit the image to optimize the positioning of the balloon. On peut passer en champ de 22.
You do optimization with positioning in this AP caudal, or you also change this is to position distal marker?
We're going to use for the POT in the left main, we use two different views.
Exactly.
Usually right coronal view and left caudal view. So let's check with the stent boost first.
Beautiful.
Okay.
Maybe a bit too far, no?
So I just get some...
Check in the spider view, yes.
Yeah,
spider view.
In spider, it will be less foreshortened, so...
Yes.
OK. Et on va injecter. Ouais. So let's have a small injection. So what do you think?
I think we can maybe... I think it's okay.
No?
I think it's okay.
And that's an NC balloon, right?
We probably need to do a second POT because we can see that we are not covering the very first strut in the left main. And we'll check that with the stent boost very soon.
OK. So the balloon is fully open. 15 seconds, 11 atmospheres. And as Bernard said, it's very important to optimize the proximal part of the stent. So I remove a little bit the balloon in order to get to the proximal strut.
We can see very well the shape of the stent and the fact that the very first part of the stent is not open.
It's a usual scenario when you correct distally that you need to pull it back to make sure that proximal edge is also fully expanded.
OK, c'est bien là. C'est bien. Ouais.
And you need to know relationship between distal proximal marker and balloon shoulders in order not to be when you inflate outside of the stent.
Okay, maybe we can do another stent boost just to check whether we have corrected this under expansion. You can see the difference. Huh? Clearly now it's a proximal part is open.
Okay, so
we are going to take a third wire.
So, Bernard, you're being challenged here by Yoshi Murasato in terms of this concept of not kissing your side branch. So this may be more relevant to your left main than to the diagonal bifurcation. But is there a risk of unfenestrated restenosis by not performing the side branch dilatation?
You mean on the circ, you mean?
Yeah.
Yeah, I think, of course, what the KISS trial is showing was really dedicated to non-left main bifurcation. I think we don't have a full answer for left main bifurcation. And in our practice, we still use kissing balloon on a regular basis for left main lesion. So maybe there is a need to redo the KISS trial with left main bifurcation. I fully agree. The question is valid.
Result looks very nice now angiographically. What is your decision making at this point? Routine kissing or evaluation of the plaque and carina shift?
We are going to do a routine kissing in this situation because it's a left main. Okay. But as I just said, I think we need more evidence. It's more experience-based strategy than evidence-based strategy. So
for large side branch, actually circumflex is not really a side branch. It's in 95% of cases really clinically relevant branch. You routinely recommend in your center kissing.
I tried to go toward the LID, and by pulling back to jump into the circ in order to go toward the distal strut. So I think the positioning of the new wire is okay. And if you agree, I can remove the jade wire.
Thierry and Bernard, I know it's not your standard practice to image at this point, but mindful of the fact we have the expertise of Yoshi and at least another 20 minutes of broadcast, would you consider an OFDI run now to assess that cross in terms of distal cross into the cell of the Nagomi?
Yes, we consider that, but we decided not to do it because we want to do an OFDI run after the KISS to check if we have any underexpansion, any malposition, and to correct them if there is any, and to do final OFDI. And we want to limit our evaluation to 3 runs in total.
So now I remove the jade wire, and I obviously take care of the left main. So that's why I'm in the aorta now. I prefer to keep the guiding catheter in the aorta than to create a longitudinal compressor. So I feel some resistance, but it's quite usual. Now it's okay.
Okay. Again, all these maneuvers are extremely important to keep the integrity of the stent.
So there's some questions here procedurally, Bernard, regarding the kissing inflation. So you mentioned pot side pot in the KISS study. Is there a role for pot side pot in this left main, or will you always kiss?
You usually kiss, but again, we don't know which one is the best approach. And I think there are some data coming from different centers, particularly bench data coming from the group of Finney, promoting the pot side pot sequence instead of kissing balloon. Again, to be frank, to be honest, our practice is mainly kissing balloon in left main. But why not post-tripod? Again, no data to go in one direction versus the other.
Bernard, speaking from the experience of many years of doing KISS pot, the major benefit of KISS instead of just simple side branch balloon inflation is that in addition to optimal expansion of the stent in the polygon of confluence, you also position carina in the center. You will never be able with pot side pot to be sure that you position carina in the center. And from the perspective of computational flow dynamics, I think it's very important to maintain carina in the center. Do you agree with that?
I agree with you. This is true, but unfortunately, in the KISS trial, again, it's not the left main lesions. We could not reflect clinical benefit of kissing balloon over pod-side-pod. The trend in terms of periprocedural AMA is going in the other direction. A little bit better outcome with pod-side-pod.
I think it's just too early to expect the benefit. This flow dynamic after stent implantation will take probably years. Like in the syntax, up to 5 years there was no difference in outcome. After 5 years we start seeing more events. So I think we need to be patient and keep following those patients and eventually see.
I agree. I agree. This is why we are going to perform a KISS today.
So I think we are ready for the kissing balloon. We selected two 3.5 balloon by 15 non-compliant balloon.
Tire un tout petit peu la circonflexe pour pas finir dans la zone de la plaque.
Maybe before the
So we have
ballooning, I usually check the OFDI.
You do?
Yeah.
Yes. But that's not the Massey practice. So. And why non-compliant over semi-compliant? We're getting lots of questions as to whether this should be semi or non-compliant. What makes you select non-compliant?
I think it's to avoid some dog bone effect and to reduce the risk of dissection.
Okay. And there's another question. There have been a number of questions regarding the potential role of drug-coated balloon, as we've seen across the meeting. Holger Neff asks if we should be using drug-coated balloons in the side branch. I wonder whether that's something you've trialed, Bernard.
We don't have really an important experience with using drug-eluting balloon in the side branch of the left main. So again, I know that some centers are doing that.
On peut à 10. On peut lâcher.
Francesco, any comments as a procedural analyst so far? Something that has to be specially described or enhanced?
Well, honestly, I want to emphasize the fact that the operators, despite that had their intravascular imaging modalities ready into the cath lab, decided to plan the selection of the strategy, two stents, sizing for POT on the basis of baseline OFDI, and then they checked technically the appropriateness of the steps on the basis of the stent enhancement tool. This is very bright approach because if we are using OFDI, we know that each pullback requires contrast, so it really makes sense to plan and then to follow the plan carefully by checking the response of the device, in this case the stent, to the ballooning sequences. I think that this is my main teaching message here.
Yeah, yes.
Well, yeah,
I think
totally
if you
agree.
can comment briefly the stent boost, I think you can see that we have a little bit of scaffolding of the circ with distal wiring on after the kissing. You can see really that on the stent boost, and we see also the nice opening towards the circ.
So how about repot at that point? What do you think, Bernard, Yoshi? We go for OFDI run or we go for repot?
I think we can do OFDI now and we'll finish by repot or any additional post-deal we need according to OFDI. So I think we are ready now for doing the OFDI check.
You are preparing for OFDI. A few comments from the
but there might be one consideration. So I actually really would like to see an OFDI now because during the procedure it seems that the balloon in the kissing situation slipped twice.
Yep.
So I would be concerned if the carina is exactly in the middle. And there is, even in stent boost, also small signs of not a totally regular CX ostium. So I would really like to see an OFDI at this stage to see if we're really successful.
They are going to do it now. Maciej?
I just want to share my tips how to reduce contrast when you use OCT, because we are using more and more CT OFDI now. So if you forget about your old habits, like doing final angio with wires, without wires, this projection, that projection, because you don't need it when you use OCT. So you just do one angio with OCT catheter because it's so tiny that it will not influence the picture. And that's it. You don't need to repeat angio without wires in different projections, because you know a lot from OCT there. If you don't see any dissection, plaque protrusion, or stent under expansion, you will never see it on angiography. So you can just forget about old habits which are not necessary now.
Yeah, and the length of evaluation with OFDI is significantly improved.
The software allows you to extend up to 150 millimeters. So there's a huge amount of customization available within the Terumo FDI system, so allowing you to go short to long. Now here, the long pullback would be useful in the initial morphology assessment pre. Now we probably want higher resolution, so I'd imagine that Yoshi is bringing down the length of acquisition to achieve we get the greatest amount of resolution of the stent within both the proximal left main and
but
LAD.
he will evaluate definitely both stents with the same run.
But I'd echo Maciek's comments about using it systematically and using the acquisition as your angiogram means actually the contrast load becomes a non-debate really. Now, obviously, we're waiting for data from the October trial, excitingly, that will be reported at ESC in terms of whether using a systematic OCT-OFDI approach to guide wire cross and subsequent optimization is necessary. But clearly, that's the experience of our Japanese colleagues. So we can see your OFDI, Yoshi.
Yoshi, can you please comment? We can see you are preparing for...
Just ready to pull back. We can't quite see on the right-hand side are the automated selection for length and speed of pullback. Look like reasonable pacification. So take us through, Yoshi, if you can, exactly how you're evaluating this post-stent imaging run.
So maybe I need 1 minute to process the images, but I want to see that the distal edge dissection and the stent expansion. I think these are the two main components to see that if the result is okay. And I also would like to show the opening of the side branch, diagonal, also the circumflex.
So that in total was an 80 millimeter pullback, and we see really very nice clearance of blood and excellent visualization of the stented segment. So while Yoshi's processing that, maybe Yoshi in the room, how are you using your OFDI?
So from this image, it's quite better, quite good, and usually we make a 3D image to see how open the side branch is tuned. It's easy to evaluate correctly. So only a 2D image, that sometimes it is a little bit complicated. But from this image, there's a very small incomplete setup position, but maybe it's acceptable. I think.
So you see some slight eccentricity there with the malapposition in the vessel.
Yeah, this is in front of the circle.
So obviously that distal cell cross was with the hope that then you place the struts that may well have been jailing the side branch across onto the lateral wall.
Clear the circosteum.
And I think it's important to go back to considering the stent technology in terms of this two-linker type approach.
We will show a few more slides, but we want to finish procedure first, and then I will ask Dr. Kinoshita to show direct bench comparisons, just to lead us through the difference in Tansei versus Nagomi.
Perhaps now it's worth to just remind you that what we are looking for now. So first we should start with the distal part of the stent and check two things: whether there is any dissection, especially paying attention to deep dissection going to the media on the longer stretch of the vessel. And the second thing, what's the plaque burden? Yeah? Plaque burden should not be more than 50% of the vessel area. And then, of course, you review the whole stent and you look for two things: malapposition and stent under expansion. Of course, OCT is very, very sensitive, so it will show you any malapposition, and you don't need to react to most of them, because most of them will cover. This is early malapposition, that it will be covered by tissue anyway. So if there's more than 300 microns on the longer stretch of the vessel, like 3 millimeters or more, then perhaps it's worth correcting this with low pressure but adequately sized balloons. So don't take then high pressure NC balloons, just bigger balloon and low pressure, because we need only a few atmospheres to move the struts of the stent towards the vessel wall.
Yeah, Yoshi's finished.
So, yes, yeah, I just finished some measurement and also the interpretation of the images. Maybe I will show the image first. So this is a pullback from the distal to the stent. I think stent edge, there's no dissection visible. I think it's well landed in the in a part of where the disease is minimum. There is a small malapposition, but it's not really the major one. There's a side branch coming. We have some concern about expansion of the stent around the diagonal branch, because there was some calcification, but I must say that after the bifurcation, the expansion is relatively good. I just measured, it was 3 millimeter. There's an overlap segment of this two stent, and I think mid part is also expanded well. And now it's come to the left LAD ostium. There is a small dissection, but it was completely covered by the stent. The opening of the side branch circumflex is very wide. I think there's a minimum amount of the metal in front of the circumflex, and there is a small malapposition in the proximal left main, but I think it's quite a small malapposition, and probably it's negligible, because I just measured the sum of the malapose strut. It was only 70 microns, so it's actually touching to the vessel wall if you consider the thickness of the strut. The proximal part expands very well up to 3.94. This is the ostium of LAD, which is 3.1. The mid part of the proximal part of LAD expand up to 3.2. This is just around the calcification. You could see that it shows that the expansion of at least 2.93 millimeter, which is the I think good expansion, and also the distal part of the stent is expanded up to 2.5. So I think it's a quite good result, and if we have a time, we can also show the ostium of the circumference.
In the meantime, we'll perform some angiographic control, because we have to keep the angio.
Yoshi, while you get that three-dimensional reconstruction, we couldn't quite see the values, unfortunately, because they were cut off on the right-hand side of the screen. But it looked like you had a stent area in the left main of around about 12 millimeters squared, which I think is an important observation in the historical setting of aiming for 8765. This vessel is clearly much larger than that, and that's not a target we should be considering.
Yes, yeah, I totally agree that the historically this Kang's law is applying the 8 as a cutoff for the expansion of the left main, but I think for considering the diameter of the left main was 4 millimeter, I think you need to really get to the 11 or 12 square millimeter. If you really have a full expansion of 4 millimeter, it will be 12 square millimeter. So.
Okay, so this is the angio result, which seems to be really great, and good news coming from the patency of the obtuse marginal and the two diagonal branches. So angiographically, it seems to be a good result.
And in the meantime, Yoshi has done the 3D reconstruction.
So this is the opening of the circumflex. You can really see that there's a minimum amount of the metal in front of the circumflex. There might be one strut a little bit in there. I think probably the circumflex was larger than 3.5. That may be the reason why you have a little bit of the metal here. But I think in terms of opening, it's quite enough achieved.
Yoshi, could you just rotate it again, just slightly? Because would your interpretation or Professor Kinoshita's, there was a link across. Had we done that OFDI prior, we've shifted the linker that was across the side branch to the right-hand side. Yeah. Mm-hmm. And I wonder then also, once we've had that answer, Jens, whether this helps you in terms of satisfying that issue with
actually
slippage.
From this 3D image, that just the last side is maybe link of the stent, so that it is difficult to open wider more, but it's very acceptable.
Yes. So a good result. Obviously, you can't dictate where the linker falls across the side branch.
Exactly.
But the importance then of having done this subsequent kissing is that we've cleared that.
And you cannot do much about this. If you link lands across the side branch, then it stays there.
This is a good point of the new arch monster. So this is a 10 crown.
And let's go back to Massi for final comments regarding the case before going to interviews. So Thierry and Bernard, thank you very much. I think it's excellent demonstration. 2 times provisional, 2 complex bifurcations, left main and LAD diagonal, but both solved with a single stent. Summary from your side?
Yes, I think it was a nice example of what we can achieve with a provisional stenting strategy with 2 different types of bifurcation, left main and non-left main. It's also a good example of the additional value of WebDI evaluation, and thanks to Yoshi for doing that. And it provides to us very important information in terms of sizing, and I think for us it was also very useful. So it's now time to...
Congratulations.
Thank you. Thank you.
Now we would like to have 2 interviews with Yoshi Onuma and Bernard Chevalier to discuss the benefit of intravascular intracoronary imaging, and I let Tom discuss it with Yoshi. And then you saw the latest generation Nagomi that we will try to present by Bernard in a new registry, prospective, large size, to test in complex patients the benefit that we may expect from the improved platform. So they will connect very soon. And then when we finish, I'll ask you to show those slides, and then we finalize the discussion.
So we've had lots of procedural questions during which, if we're waiting for Yoshi to come, we can answer some of those.
We can discuss some of them before.
So there was a question around drug-coated balloon, both side branch and main vessel. Should we be considering that? I don't know whether you have an opinion. I do, but...
Yeah, I think we didn't touch the side branch. I mean the diagonal, so there's no risk of restenosis there. We know that even when side branch is pinched, even next day it looks better, and following days it may be even improved. So I don't think there is a role of
there is some tissue edema. You expand and actually elliptically deform that ostium, so the area is actually preserved. Just in projection that goes orthogonal does not look very good. Other questions?
And then questions around really how to undertake the kissing. Jens, I wonder if you want to answer that in terms of how you size side branch, main vessel, circ and LAD, whether you use non-compliant or semi-compliant. Is it different for provisional or 2 stent? Sorry, that's a lot of questions, but technically, how would you approach the
Francesco may
kissing?
help also with
if you would draw some of it.
So the selection of the size of the balloons for kissing balloon inflation should should have a rule for the main vessel. That is, do not undersize the balloon in the main vessel because you want to keep the optimal expansion into the stent. Regarding the sides for the side branch, I think that there is no strong rule. If you have disease to be treated, it makes sense to have a bigger balloon. If you are just fenestrating your side cell of the stent, you may perform a compromise in order to minimize the risk of side branch dissection.
Thanks. Yoshi is connected. Maybe Tom, we can.
Yoshi, that's the most incredible backdrop. To be flying through the coronary is proper high tech. So we've seen beautifully from you the benefits of OCT in OFDI in the initial assessment for morphology and then in the optimization. Do you want to take us through where you see the role of imaging in this type of complex intervention?
Yeah, thank you, Tom. Maybe can you advance slides next, please? Yeah, so this is the role of the optical coherence tomography of FDI in left main PCI. In general, before procedure, you can really doing the diagnosis, looking at the plaque distribution, carrying angle. There is a role for the during PCI and also after procedure. Go next slides, please. So go next. So the before procedure, as shown in this case, that you can really identify and understand the bifurcation lesion. Also, you can really assess the severity of the disease. In this case, the minimum lumen area of the left main was 4.4. It's significant. Plaque distribution, like calcification, lipidic plaque, is important. Also, you can use this image for the sizing of the stent. Go next, please.
To go back to the last slide, if you can. So there have been a number of questions, and it may be a good opportunity if we just go back to the last slide. You've measured lumen. You've measured lumen. Is there a role for measuring external elastic membrane?
Yeah, I think it's a good point. Especially for the left main, it's probably difficult to look at the EEM because the size of the left main is big, and in this case also there's some plaque. So I think for the left main specifically, personally I take the lumen consistently from the proximal and the distal, so that we are somewhat consistent in the sizing. Okay. But of course, if the penetration is enough, you can measure the EEM as well.
Fine. And that would lead on just to the next question, which is, should there be a battle between IVUS and OCT? Is one better than the other, or can we use both?
I think we can use both, and the absolute solution would be the combined catheter, where you can really use both technology at the same time, so that you can see the plaque with the IVUS and precise measurement of lumen by the OFDI.
Next slide.
Go next slide. Yeah. So during the procedure, after putting the stent in the main branch, after the recrossing the wire, you can really look at the 3D OCT to avoid the external wiring or the metallic carina. In this case, you can really see that the wire is outside of the stent. Go next, please. This is a phantom of the Nagomi. We just try to look at the opening of the side branch. I think the live case, the last 3D is a little bit looks like same pictures. Go next. So yeah, in human, I think if you have a 3D reconstruction, you really assess the opening of the side branch. Go next, please. Yeah, sometimes also there is a deformation of the stent. I think the operator was, in this case, very careful. But in this case, we detected the shortening of the proximal part of the stent with 3D reconstruction. Yeah, last part is the stent expansion, malposition dissection. Yeah, stent expansion, I think we discussed with Tom during the procedure, but I think it's better to measure the reference area distally and proximally, but sometimes in the left main, it's difficult to look at the reference diameter of the left main. So you can use the absolute value. Kang's law is 8 square millimeter. Go next. Maybe you can sometimes use 8.5, but in this case, we know that the left main was 4 millimeter. So if you calculate the circular expansion of 4 millimeter stent, it will be the 12 square millimeter. So I think in this case, it was a good expansion of the left main. Next, please. Yeah, next, please. And yeah, for the malposition, I think Maché already mentioned, I think distance of the malposition is important. Up to 300 micron, it's naturally resolved. Length is greater than 1 millimeter. You can consider the additional post-dilatation. For the dissection, if the width of the distal edge dissection is equal or greater than 200 micron, you might consider the additional stent. Yeah, thank you for attention.
Thank you, Yoshi.
Thank you,
Fantastic.
Yoshi. We would like to see now Bernard and discuss the new study that is in a planning phase. We already enrolled first patients, and several centers in Europe will be open to test in the most complex patient population the latest platform of Nagomi with a clinical endpoint, target lesion failure. So we will see whether we are able to achieve the expected reduction and improvement in clinical outcome. We know that there are differences compared to previous generation Tansei, and I'll ask you, let's first finish interview with Bernard, and then we will show the comparison in a bench and why we base our expectation on improved also clinical outcome for design that is significantly improved. In my best knowledge, this is the only 3.5 that according to IFU can be open to 625. So from 3.5 to 625, which really simplifies the way we do left main PCI, especially if we want to use longer stent and be on the safe side with the distal. Bernard, we see you, and congratulations again on excellent step-by-step demonstration of provisional. Our goal, as I said, was to discuss available evidence and then planning of a new study. So what are the brief, the heritage and clinical evidence that Ultimaster family has so far?
Yes, I think significantly important and large evidence has been built on Ultimaster trial coming from Discovery 123, which is about vascular repair, to Centauri 2, which is a head-to-head comparison. Ultimaster, a very huge registry, worldwide registry, and MasterDapt regarding the capability to do very short DAPT in high bleeding risk. So in this heritage, we have to go now to the next step, which is Nagomi complex trial. And I think we'll discuss that in the
trial.
In the next minute. Yes, it's a prospective, multi-center, single-arm post-market trial with 50 to 60 sites in Europe, with a lot of quality in terms of data, and this is very important, including QCA for bifurcation, and including very important patient-reported outcome, Seattle questionnaire, the EQ5D in terms of quality of life. And this trial is dedicated to complex lesion, 3,000 ischemic risk, high ischemic risk lesion, with at least one of these criteria: MVD, more than 3 stents, more than 3 lesions, complex bifurcation, CTO left main, long stenting, severe calcification, ISR. And primary endpoint will be TLF at 1 year, and now the enrollment is starting in this very important endeavor.
Thank you very much, Bernard, and congratulations again, and a warm welcome to Paris in this afternoon, probably to discuss further the details of new studies you are planning. I really like very much your idea of repeating KISS in the left main, and looking forward to participate in that one. Thank you very much, and all the best.
Thank you, Goran. Thank you, everybody.
Thank you. Now we are back here, and Dr. Kinoshita would like to show a direct comparison in a bench with potential advantages of Nagomi versus Tansei.
Thank you. Thank you, Goran. so that I would like to continue my result of my benchtop test. So as you can see, the real clinical cases today, the Uchimasa Nagomi is a very, very good, suitable for the bifurcation region. So in this 60 degrees model, as you can see, the upper left side is the Uchimasa Nagomi. This is the Uchimasa Tansei. So as you can see, so after kissing bound rotation, the Uchimasa Nagomi is completely fit this bifurcation model. But unfortunately, the all Tansei is a little bit so the overexpanded around here. So also the side branch ostium, we can see the overlapped strata like this. And more wider model, the angle, this bifurcation angle, the 19 degrees model, this is also the same result. The Uchimasa Nagomi is completely fit this region, even this wider angle. But also unfortunately, Uchimasa Tansei is a little bit incomplete position and overexpanded part and a little bit. So we can see the limitation around this model. So we want to keep this one. And now the Uchimasa Nagomi has up to the 15 millimeter length. And also in the large vessel design, the 10 crowns. It is impossible to up to 6.25 millimeter. So then this means that the new Uchimasa Nagomi is a very, very particularly suitable for the long region and large vessel bifurcation region. And in addition, the Uchimasa has demonstrated in the safety in the high bleeding risk patient. So from this result, I think that the new Uchimasa Nagomi is a very, very good choice for the bifurcation region, long region. So it means a very, very truly complex region. Don't forget, this is a very, very important thing.
Thank you very much. Thank you very much, Dr. Kinoshita. I'm sure we have several questions waiting for the discussion. Tom?
Several questions. We've got an incredible amount of discussion. So we've had lots of stuff around the procedure, but I wonder, Yoshi did then bring it back to the high bleeding risk patient. And so there have been a couple of questions around both peri-procedural anticoagulation. Do we have to do anything different? And then maybe we move forwards to beyond the stenting.
So the practice Maciej.
Yeah, so considering a very the simplicity of the procedure, so 2 bifurcations, but both treated with 1 stent. Yeah, so it's the simple procedure. Then second thing is the optimal result, yeah, because we check it with OFDI and the result was perfect. And the third thing is the stent, which is well known, although Nagomi is new, but the platform is similar to Ultimaster, and we have enough data on the safety of the stent, even in more complex scenario for shortening DAPT. I think in this high bleeding risk patient, I definitely would not go longer than 1 month. So dual antiplatelet therapy for 1 month. And then, of course, the patient has to stay on anticoagulation. So there is a question of how long should we keep it on dual anti-thrombotic therapy. And then I think that 3 months will be optimal. We do not need to prolong over 3 months, and after which time the patient should stay on just on apixaban. Perhaps one more word about apixaban. There is no indication to reduce the dose even in the early phase, so triple or dual twice a day, 5 milligrams, because the patient is not very elderly, not over 80, not weight below 60, and
without severe
of creatinine.
Yes, your practice similar or different?
Well, yeah, I'm totally agreeing in all this consideration here, but the factum is actually that we don't have the evidence. We are extrapolating from other situations and from the guidelines. And that actually emphasizes one of the things that we need to address as operators, mainly keep the procedure simple if possible, do the best possible job, and check that we have really delivered the stent the way we liked. Because when we don't really have the evidence, we at least have the chance to do as good a job as possible when we go lower.
Other questions?
Yes, so just to extend the MasterDapt experience, I think is interesting. You said a few months, and I'd challenge you, how much is a few months? Is it 3 months? Is it 6 months? Is it 9 months? Even with a protocol dictated by MasterDapt, which was 1 month triple therapy, and at 6 months stopping the antiplatelet and going back to the DOAC, we saw many physicians not prepared to stop the antiplatelet. And the really interesting analysis around that was that there was an excess of bleeding in those patients who persisted with antiplatelet. Now, whether that reflects this type of more complex intervention, I have to say in my practice, it's given me reassurance that I can go back to a DOAC monotherapy after 6 months in a patient with true high bleeding risk.
Definitely. I think this is the largest size study evaluating potential risk in that kind of patient population. And the bleeding risk at 1 year in patient population with high bleeding risk, according to ARC, is really very high, with significant impact on directly on the outcome. I don't know if in Denmark and maybe Italy there is acceptance of this kind of practice and use of master DAPT to be more aligned with the shorter duration, because the evidence, as Tom said, of extending beyond the point is really increasing bleeding risk without improving outcome.
Well, there are, but again, we have all the same considerations that anywhere else. If you go for clopidogrel, is it totally covered at that patient, or is there genetic variations? If they are on AFib medications, what about the platelets? Is aspirin really valid anymore? All these considerations are there. So when we come back to the guidelines, we actually faces that when we decreased the 12 months in acute coronary syndrome to 6 months, it was actually difficult to adhere to that. So we tend to give too much. But this is a kind of a learning period for the colleagues.
Francesco, in your practice?
Over time, I think that this is the perception that bleeding risk is a strong modulator of patients' outcome entered the clinical practice across Italy. Still, I think that the adherence to the idea of coming back after unprotected left main PCI within 6 months to just oral anticoagulant is something that is outside the routine practice. And honestly, I mean, it is an area where we really need strong and accurately empowered trials to be 100% sure about the safety.
Exactly. Dr. Kinoshita, in Japan, what is the current practice of triple dual therapy in these high-risk patients?
Yeah, so actually, so usually we try to continue the DAPT at least 6 months. But in the high bleeding risk patient or the patient who have to take some surgeon, at that time, so we choose a stent, which can be stopped the DAPT in 1 month, like Ultimosta or Xience or something.
Okay. Some technical questions, procedural?
Yeah, well, actually, to come back, I wonder, Francesco, whether we use an angiogram to try and answer this understanding of where you place your stent proximally. There are some people still concerned about going for the body or shaft of the left main. And if we are to drop it ostially, how do we overcome this issue between potentially the roof and the floor being out of line?
Well, so I think that there is no final answer for that, because we know that the ostium of the left main has this oval shape in which you have the root that is, in the case you are aiming at covering it, is strongly associated with the risk of having protruding stent struts into the bottom part of the ostium itself. So there is no final answer for that. For sure, before embarking in not covering the ostium, it is very important that you are 100% sure that your landing zone has been appropriately selected, and intravascular imaging can help you. In the absence of documentation of absence of disease or correct landing, I think that we should accept sometimes to have some protrusion. And again, it is the typical phase of the procedure in which you need to deserve time, good incidents to really properly place the stent. And anytime you had the impression or intentionally you protruded outside, you should recognize the fact that you increase the risk of longitudinal distortion over there. So when we practice this, we always perform a POT that exceeds a lot the ostium, so that we flare the ostium of the stent. This seems, according to our practice, to increase the safety of ending at the ostium of the...
Final words, Maciej?
Just this case was a beautiful demonstration how to avoid this dilemma, because if you do imaging and you see there is no significant disease at the ostium, you don't have to cover the ostium, and there is no such a dilemma.
Yes, final comments?
Final comment is that we also remember that there is elastic tissue in the ostium of the left main, which means the recoil potential is bigger in that area. So that is a concern when we are placing stents in that area.
Dr. Kinoshita, final comments?
Yes, in this case, especially bifurcation region, the OFDI is the very best modality of the imaging. We can evaluate the preliminary everything, bifurcation, the stent position. So I think that I prefer the OFDI.
OFDI. Okay. You worked very hard throughout the session.
Yeah,
final comments on your side?
Well, I haven't necessarily answered all the questions, so I typed away. Massey always make it look simple. But I think we acknowledge that we have new stent technology that's providing us even greater option, the ability to expand across significant discrepancy. And we've seen the utility of OFDI in ensuring an optimal result, particularly in a patient with additional complexity through high bleeding risk. And there is evidence, and we should thank Terumo for pushing that in terms of the MasterDapt study in telling us how to manage high bleeding risk patients.
Thanks, Tom. Thank you very much for attending this session. Thank you for being so interactive. I would like to thank the team in Paris. Of course, in Massy, I would like to thank all the discussants and speakers. And of course, I would like to thank the Terumo for setting up this session. And I wish you a successful meeting. Bye.